talk about in community level programming?
Yeah, so when you dive into the actual recommendations, they're themed, like I said before. And so there were some particularly where, an overdose prevention strategy might look different for someone who's unhoused rather than if they're housed, right? So there was some education and outreach there as well. Most of the why is agnostic to who, right? So this idea that like people need access to primary care and to ongoing treatment and to overdose reversal medication. How you get people all of those things can really vary on some demographics. But the what is pretty consistent. The other thing that was really interesting is that you'll see in their recommendations specifically to the faith community, because when we think about healthcare and substance use disorder, sometimes we're forgetting that there's really a whole person approach, right? And so in one of the cases, we had really seen an interaction and a supportive, protective environment from their faith community. And so we were looking at enhancing that across the rest. And so there are some things that are specific, but because it's designed to be a broad-based community intervention, it doesn't get too specific. There are some fatality review commissions that get very specific to very specific cases, but sometimes if you go too narrow, it can't have sort of the broad-based community impact that this commission is focused on.
And tell me if I'm wrong, but I mean, our focus is to identify problems and then direct them to groups that can make the changes, of which I think this group that we're here right now is one of those groups. Am I correct?
Right.
Okay. Are there any other questions?
I think Kim McNamara had one.
Kim? Okay.
Go ahead, Kim.
Go ahead, Kim.
Thank you. I'm not sure if this is the right place to ask this, Jennifer, but I'm going to try it anyhow. I don't know how involved you are with the dispersing of the opioid settlement funds, but if these goals that you've come up with here, such as expanding access into places like primary care and that sort of thing, can any of those opioid settlement funds be used, a percentage of them, in combination with grants and other funding to actually improve the outreach to primary care, such as mobile health services or something like that?
Yeah, so the Opioid Abatement Advisory Commission, of which I am on, and so is Representative Nagel, is part of why these conversations are happening, because we're saying, okay, there's things in these recommendations and things that are going to go into the ship, and who's going to pay for it, right? And so then there's these other buckets of funding. And so the recommendations in this report around primary care are really around the fact that we know in general that a medical home is protective to all sorts of chronic fatal conditions, right? And so one of the first things that I ask of the medical examiner's office is for the primary care physician's information on the decedent. Oftentimes there isn't one. And so in this case, it's the lack of information that indicates to us a lack of a medical home as a risk factor for a fatal overdose, right? But to your point of who pays for it, how is it paid for, is a good one. And I would be remiss if I didn't say we've come a really long way. So we have really big hospital systems that are doing a really good job integrating addiction care into their primary care settings. And so we even have some hospital systems that I think we could all point to and say, here's sort of the best practice. Here's how you utilize grant funds to pay for an addiction medicine program. Here's how you fund uncompensated care and those sorts of things. But the more that we talk about substance use disorder as a chronically relapsing health condition that should be addressed in a primary care setting the same way a tobacco use disorder would be, right? If I want to quit smoking, I call my PCP and they do social educational counseling with me and they put me on medication and then they follow up with me. A lot of addiction should be treated that way. And so the more that we're able to expand and use tobacco as sort of that reference within the medical model, the better. I'm not saying that substance use disorder isn't very, very complex, because of course it is. But the more we think about it as the medical condition that it is and enhance all of our medical care surrounding it, the better.
If I could add to that, that's awesome. I mean, the role of the Opioid Abatement Commission is actually to hand out money, basically. So if you have a program, a plan, a thought that can't be funded in some other manner, you can apply for funding. And the nice thing that I think that we've done in this state that's very unique is that we decided to be very nimble. And if you can keep your funding request below $75,000 per year, it actually goes through a separate process that can be done very quickly and thoughtfully. Anything over $75,000 has to go to the Governor's Commission or Executive Council and Governor's Commission. It's a long process, but if you keep your dollar request low, you can get approved fairly quickly. The other thing is there's, I believe, 19 indications that we can, by statute, provide funding. I think that would fit within that. We're really focusing now on primary prevention. We've already focused on harm reduction. But access to care is part of primary prevention. So, yeah, that's how that works, at least that element of it. If we have any money left after everybody else is taking it from us. My cynical comment. Other questions?
I just have some observations when I think about this. I'm not clear how well this information gets closer to providers and to the patients we serve in a way that's accessible and actionable. So it's just kind of a, I don't know. And when I look at rural compared to urban, I find categorically one of the challenges in rural is too few people over too many miles, creating a challenge for effective, efficient, and financially sustainable solution sets. So then I started looking at asset inventories of where are there community assets that could be additionally or repurposed. So I often come back to libraries as an interesting construct for a variety of things. And then when I think about substance use disorder, I think that it's a vestigial anomaly that we actually separate ethanol from nicotine from everything else. It's a political or a Puritan convenience or a matter of taxation. We are a funny species or a funny subset of that species in this country. From a pharmacokinetic perspective, in which I invested 6 years of my life, I really don't care what the substance is. That's cute, but it's usually a pejorative statement. So I think that's something of how do we language it to get the results we're looking for, because the current languaging isn't getting the job done. And I think language matters. And that's kind of an open question of, in oncology, I have a very close relationship with someone who takes offense if you refer to them as a survivor. They will come back and look at you and say, I don't live there.
Right.
Stop calling me a survivor. You're like deeply offended. And they don't filter, so they will just call you out on it. So just some interesting observations of how do we get this into the hands of the primary care? How do we invest in things that have sustainability beyond whole milk left on the counter overnight, because these funds will not last forever? And then how do we get upstream? You know, so we're dealing with a mortality and morbidity analysis. So it might be interesting to take some of these case studies and actually do a tracer analysis. Walk them through this system. How many times did they hit the ED that they didn't get? Did they get referred to primary? Did they go, here's a call? Did they? I mean, is it like, oh, you should call, or did they actually do a warm handoff? Is where are the gaps, and how much variation do we have if we have positive deviation that someone's got it, like they're doing really good work? How do we replicate that? And how do we adjust for urban versus rural? The Doorways works beautifully in urban. It struggles in rural, because there's too few people over 2 miles, and we don't have paid fire departments. So there ain't no one there, and the doorways in the North Country is a 9 to 5 thing. So if you're gonna overdose, please do it Monday through Friday between 9 to 5, and we might be able to help you if we can fit you in. But you need to schedule that overdose. I mean, how rude to overdose on an unscheduled manner. That's just not nice to the providers, right? So anyways, great work. I love it. Now I got to go look at it and figure out, what can we do in the North Country with it? How are we doing? Because luckily, thankfully, the N values are relatively small. We'd like them 0, so we don't have to have this conversation. So thank you for what you're doing.
Yeah, great points. I couldn't agree more that we stigmatize certain substances for reasons that seem really strange to me. We have a lot of social acceptability, probably most for alcohol right now. Tobacco is even sort of more stigmatized than alcohol use right now.
Well, there's an interesting phenomenon with alcohol, and I smile because it's my son's generation, Gen Z. There was a beer store in Littleton that closed because they're not drinking. Well, they're not reproducing and they're not drinking. The lack of reproduction has Wall Street really nervous about a consumer-based capitalism because that'll sink it. But I kind of smile about going, so if you built your economy on taxation of alcohol, this is going to go really badly with this upcoming generation because they're just not interested. They're not
So
drinking.
we might have to start taxing other substances. Anyway, the other thing about urban versus rural is we see that in healthcare across conditions, right? That it's fundamentally harder to serve rural situations. There have been a lot of improvements in access to care around telehealth services, particularly around medications for substance use disorder that you can do your follow-ups remotely and things like that. There are recommendations in here around first responders because in those rural places, often it is the first responders who, if they were able and willing to do more community paramedicine, could start to fill in some of those gaps around the healthcare needs in the North Country. But again, when you're dealing with state police who are on call, it's really hard to get there fast, particularly in the events that are most critical, like these overdoses.
When you have time, not for here, but follow up with myself and David, I have a thought on a pilot project that may help resolve the too few people over too many miles as it relates to the Doorways program, leveraging some capability.
Let's talk more.
I think that also fits into the role of this group is that we are looking at top-down, down-top coordination between public health networks within the state and us, and they know their communities a lot better than most of us do in some ways, and that may be a way, if we choose that as a priority, that we can use this group to accomplish the goals of that group.
Question, so the data that's reviewed by this group is related to fatal overdoses, but there's not sort of like a counter approach of looking at people who have successfully recovered?
Yeah, that's true.
And that's what, so it's like like figuring out like lots of people are successfully, recovering and learning about that and what made all the difference seems equally as important.
I'm sure there's other groups that look at that, correct? I mean, our job is just look at fatalities.
So this commission is focused on fatality data, and you're not wrong that fatality data is not the full picture. Someone else in the chat asked about non-fatal overdose as well, and until we work on some of the other, mostly around stigma and the inadequate medical care that people receive post-overdose, what we will continue to see is that most people are being reversed of their overdose and never having any medical care at all. They're receiving their medical care in their community from their friends and family. And that's because they have bad experiences when they go to the emergency department because the staff there don't always treat them well. And so Nationally, they say about 90% of non-fatal overdoses are never reported. No one's calling 911, no one's going to the hospital. It's a situation where folks are, from a harm reduction approach, monitoring each other's health and well-being while they're using substances, and they're reversing each other if and when they need to be reversed. And so that's sort of a bigger cultural problem that folks don't want to access care. That doesn't have much to do with the people who need to access care and more with the people who provide the care.
I have to say, like, whenever you're solving any problem of any kind, it's you like look at what do you do right, what do you do wrong, and what can you do better. We're focused on what we're doing wrong, and I think that's a really important concept. Is well, what do we do right, and how do we generalize that? There's actually a woman that I've been interacting with from Rhode Island who was a survivor, and that's her whole focus in life is doing exactly what you just said. Using her story to help other people. She actually went and got a PhD in Brown, and she was like near death, like within about 10 years ago. So there's people doing that, but that's an important part of the equation. I just have one comment I feel obligated to always make, and Jennifer, you're always going to get sick of me saying this, but you know, I've been involved in pain care policy now for 40 years. We get data every month from the medical examiner that you all have access to on who's dying and who's not. The prescription opioid epidemic, or whatever you want to call it, peaked in 2012 and has basically gone downhill ever since. There's virtually no deaths now from prescription drug overdose. So we really need to understand that and remember that a lot of the people that are not being treated well in pain are going to the streets to get their meds because they can't get it from other sources. And we're even seeing people do that at end of life, which is really sad. But those are things that we haven't really explored in this commission, although we kind of have, because some of these cases are people in pain that use street drugs to treat their pain or self-medicate, whatever. So I said my piece.
It's also this interesting thing where, particularly for this group to think about, what we know from a public health perspective is that when you think about the risk and protective factors that someone might experience for an overdose, those are the same, if not extremely similar, to risk factors for suicide and risky sexual behavior and all of the things that you're like looking at sort of reducing across our community, right? So while this report has very specific further down the continuum strategies when it comes to overdose in particular, when you all are looking at prevention of chronic disease, of not wearing your helmet when you ride a bicycle and making sure you're putting your seatbelt on and sunscreen on when you're at the beach, right? All of those things all together, they have shared risk and protective factors. So even if you don't think you're doing overdose prevention, you might actually be doing overdose prevention.
A last thought for consideration. So where we're focusing is great, and in 2018 when we looked at the opioid epidemic, and New Hampshire is in the top two with, I think, West Virginia, we moved upstream into the schools to actually start working on the K through 12, looking at adverse childhood events. That unless we deal with age-appropriate diagnosis and treatment for authentic behavioral health conditions, as well as non-diagnostic behaviors that are unacceptable. A child may express anger, has nothing to do with the diagnosis, and the behavior is not acceptable. It actually doesn't, it's not effective either in getting what they need, is getting underneath that and starting to develop those age-appropriate strategies of resilience so that when they get in their teen years, we may see less self-harm and self-medication. Now that's that long view. This is a multi-generational phenomenon. And as you had mentioned, helmets and seatbelts and things like that, at some point in time become habituated and we don't think about it. To that point, I would encourage us to take a look at the research of the Neuro Leadership Institute, because a lot of what we do is education. And the Neuro Leadership Institute has about 10 to 20 years of research of understanding when we educate. They've married the modality of education to fMRIs to see what part of the brain lights up. So you get better stickiness, and they full well understand the 30-day process to habituation. I've only started to dabble into the Neural Leadership Institute for staff education because I chafe at death by PowerPoint and the talking head. I have ADD and it just doesn't work for me. And also, what could it mean for patient education of getting education that is accessible, doesn't have to be text-based, which is usually terrible, and actionable in a timely way that they get their neurostimulation as a result of this behavior change. So it's a fascinating area. And gratuitous plug-in, we have 5 years to play with things like this with the rural health transformation. And those sorts of things could be transformative. But I'm seeing these potential puzzle pieces. I have not had the time to sit down and figure out what they mean and how to put them together. But I think it holds some potential. I love going upstream and spending time with the kids. They're the future. So if we can set them up that we're not having this conversation at this table, we're gone, then they're sitting here.
Well, that was about the best segue we could have had. I think. So we're right about time. I just didn't know if there was any other.
I just wanted to address Tori's chat question, if
Sure.
you could. Jennifer, do you see it?
I was
She's
just
asked-
typing an answer. So it basically, the commission reviews whatever's available. Generally, that's medical records, police reports, and any corrections related information. So looking as far back as we have a history on the person, when it comes to any hospitals that they've been seen at, places that they've been incarcerated, or any sort of involvement with the police that they've had.
It'd be fascinating to go back all the way through their school records and see what we see there.
So one of the big problems we have is the whole confidentiality and all those pieces, and it's really hard.
Yeah.
Jennifer goes to great lengths to get all this information, but there's a lot of barriers, and that's always been the limiting factor. And we do.
Particularly for hospitals that are owned by a specific hospital corporation that I won't name, that's based out of state. Getting records for them is almost impossible, even though it's statutorily allowed in New Hampshire. And we have letters from the Senate chair and everyone who needs, they just don't release them. And so it really all depends sort of where the person has been seen and where they haven't. Getting records of a person who has died when they were a juvenile is almost impossible. Records are often sealed and changed. And 42 CFR Part 2 is still in place even after someone dies. So sometimes we have to pursue the record information released from their next of kin. And so it can be a real barrier. But even with the information that we're able to get, we are able to produce some pretty good recommendations. But yes, more information is always better.
Thanks, Jennifer. That's awesome.
I'm going to stay and listen.
Oops.
I do have a question, but it might not be related to the report, because I think when we talk about the SHARship, all these things that we discussed so far is great points, but where the housing part falls on this, because I think we all shared many times that housing is part of the health determinant, but we focus on one aspect. What can we do to extend this on to stress the importance of housing in this?
I'm glad you mentioned that, because that's a focus of the Opioid Abatement Commission. I was just at a Governor's Commission meeting. It's a focus there. We talk about it in that, so it is, and that's important. And I agree. Thank you for bringing that up.
Thank you, but when I didn't read the full report, because she said right now focus on 14 to whatever, I'm going to read the full report, but I really want this committee or this council to emphasize on that in meetings. Of course, we cannot prevent death and all these if they are not even housed. So I think it's very important that we dig deep in that when the time, yeah.
Thanks, Alexandra, too, for the point that she just put in, being with the New Hampshire DOJ, so that's a great connection.
Do you want to introduce Whitney, or do you want me to? Oh, okay. Okay, I get the privilege of introducing Whitney Hammond, who's going to talk to us or update us on the Rural Health Transformation Program. I just got back from Washington, and before that, Massachusetts, and I am so transformed right now that this is an exciting time for me.
Thank you.
And yeah, great segue too from Ed, although I did do slides, so you don't have to look at
They're
them.
fun.
I only did them for people who like the visual.
That's right.
Don't look if you don't want
It's a
to.
learning style issue.
And I'll ask Scott to monitor the chat for me, but I do want it to be a sort of conversational presentation as opposed to me just going over what I have learned. This is probably my 4th time now presenting on the transformation grant since we submitted it. And it's really challenging to not just overwhelm people with information when you're talking about potentially $1 billion grant. So I'm going to try and balance those two things. So the name of the application that was submitted on behalf of New Hampshire was Granite Strong, Future Ready. I think the idea behind that title was to make it a very New Hampshire, local flavor application. So I'll get into a little more detail about what that means, but largely the process that we used to come up with our application was very locally driven. And then the process that we told CMS we're going to use to actually implement this project is very locally driven. And I think that kind of speaks to the Granite Strong. And then Future Ready is really just a nod to the idea that this transformation program is all about getting basically rural health systems ready for lots of changes down the pipe, from reductions in revenue and increased compensated care. So how do I make it go forward, Scott?
There you go.
Okay.
Yep.
So just as a reminder, because I know not everybody was here for my last presentation, and also you may just not remember, the Rural Health Transformation Program was authorized by HR 1, or the One Big Beautiful Bill Act, which was passed July 4th. And in a kind of last minute negotiation to get the votes needed to pass that budget, there was an appropriation included for the Rural Health Transformation Program. I kind of touched on why that was. There was a lot of concern around the One Big Beautiful Bill and the impact that the reductions in Medicaid coverage would have, particularly on rural providers. Many naysayers, and I'm not pointing at Phil, but
But she just did.
He's the numbers guy. If you do the math, the plug of the funding is not equal to the reduction of the funding, and so there's a lot of concern over, is this really even adequate to make up for that harm that's going to occur. I have to say it's been a fascinating experience as a person who's worked on grants for over a decade. This is really different, and so it may not be what it sets out to be, but it's certainly different, and that's a good start for transformation. So one of the things that's really different is it's an enormous amount of money for a single grant. So New Hampshire stands to potentially get up to $200 million a year. Let that sink in. I was telling Scott while I was writing the grant, I'm like, I can't even get all the zeros down, I'm having to count. But
how does that relate to the entire budget of public health? Because I've asked you that question.
Yeah, so public health is probably $140 million a year. So this is one grant with a budget bigger than all of public health in New Hampshire, with about the same administrative work of one grant. So it's, again, this is transformative actually already. Sure, Phil.
And it's the same application for both the 100 million that is the sort of baseline that most states can expect, and then what you have is up to another 100 million, but we don't know what that amount will be. It could be higher, could be lower.
Yeah.
Right? Okay.
So I have a bullet here about that. So 100 million is pretty much guaranteed per state. We just submit a technically correct application. Fingers crossed so far.
Yeah.
You did, I went in Washington, they said all 50 states did.
Yeah.
Okay, good. All right.
So then the other half of the funding, which is 100 million, is going to be distributed based on essentially 3 criteria. One are our state demographics, which we can't control. New Hampshire has some things going in our favor, which is that around half of our population, per the definition in the grant, live in rural communities. So that was a favorable factor for us. But our square footage as a state, it was unfavorable. So we're really small compared to California and Texas. There were a couple other things like whether we have Frontier, which we don't, although like one national group flagged us as scoring for Frontier, which who knows? Yeah. We'll take it.
It's a minor, they're talking about Keen.
Yeah,
Cold
the
Road.
Frontier.
Yeah.
And so there's the state demographics, which we can't control. Then there's our existing policy landscape and what the governor's office was willing to commit to for future policy. New Hampshire actually stands to score really well, given our policy landscape. A lot of the federal, so the policy requirements were really designed to align with the federal administration's policy agenda, which actually is somewhat aligned with New Hampshire in terms of some things around like loosening scope of practice and having no certificate of need. And so like actually our policy landscape places us fairly well. Some of the only changes we're going to make to scope of practice, hopefully, are around letting pharmacists do actual like testing and ordering without a collaborative practice agreement, and then allowing dental hygienists to bill directly without dental supervision. But otherwise, we checked all the boxes. Another policy thing, this has been one of the like areas of joy throughout writing this, is for better or for worse, there was about $200 million worth of funding that hinged on whether we were willing to implement the Presidential Fitness Challenge again. And so it was kind of fun to hear everybody's stories of their own trauma and trial around that. So the flexed arm hang seems to reign supreme as torture. And
The
so,
sit and reach, I remember,
sit and reach.
this is 1974, and when you didn't reach far enough, your teacher would push your back and your hamstrings would pop. But it was like, that was what
I
was
do
done.
have to say that when I took it, it was really hard to pass it, so they changed the requirements and made it a lot easier to pass it.
See?
So,
But the way that we kind of wrote that strategy into the grant involved a lot more like emphasis on funding and supporting schools and communities to just improve physical activity, and just the tie-in of, and then we'll check the box on.
it's a
that we're
huge
doing
focus
this.
on prevention,
Yes.
which is a good thing.
Yes, yeah.
And you guys looked at that a lot.
Oh, yeah.
Yes.
Yeah, so I'll get into our process because I think I've largely covered what was on this slide. Oh, the only other factor, and it's, again, this is kind of where this grant is transformational. Probably the smallest factor for our overall scoring is actually the quality of our application. So, which is interesting. So it kind of like took the pressure off a little bit. But so basically they just wanted to make sure things we proposed seemed like they'd be impactful and that they would sustain after the end of the grant period, which is kind of nice.
So is the rule we wait until the end of the presentation to ask questions, or we can ask them now?
Ask them now.
So on the scoring process, you said based on demographic, and you said we cannot control that. What that looks like to them, to the new administration that we are applying, what that demographic looks like?
Only things related to our rurality, so not things like the age of our population or like what is the racial ethnic breakdown. It's really just
Or
about
sexual, like
no,
what are
none
those?
of that. None of that. Just trying to get a sense of how rural are we, because it's, again, kind of wild that they gave every single state $100 million and it doesn't matter how rural you are.
Or your population, sorry.
Yeah, so like New Hampshire, which is only like 1.3 million people, gets the same amount of money as Texas. So in this other batch of money, they wanted to factor in like a little more around, are these actually rural states?
And my understanding is that's the first year only. After that, depending on how you do or do not use the money, that could change,
Yeah,
right?
so thank you, you got to my final
Sorry.
bullet, which is,
Sorry.
funding will be impacted by our performance year to year, and again, this is a little transformational because our performance includes our spend and the impact. And that has already been transformational in terms of our approach to writing the grant, because I have never had so much like sort of ability to fast track a grant and the work around. We are currently drafting contracts right now and aiming to hit governor and council in January, which is like
Unheard.
lightning speed. So I won't get too into this because I don't want to short our time for the next presentation. New Hampshire's approach, the governor's office was very involved in the approach for developing the grant and also giving input into the priorities. I snapped this picture on my way into the governor's office for one of many meetings that we had and painfully learned they really don't open the doors until after 8 a.m. So I stood outside in the cold. But so governor's office is very involved. They asked the Department of Health and Human Services to lead the application and submit the application. It was, again, a really cool, very different approach in that they designated public health and Medicaid as co-leads on writing this grant application. So for the last like 6 to 8 weeks, I literally sat across from the deputy of Medicaid as the deputy of public health, and we sat and co-wrote this in a room together. So it's very like thoughtful about how do we do sustainable, you know, payer funding for what we put in here. We also used a staff of, including I think Jennifer was involved, 30 plus subject matter experts from within the Department of Health and Human Services across public health, behavioral health, Medicaid, really even into SNAP and like a couple other places. And then the governor was adamant that we have an RFI process, and that the RFI process, I think it was only open for 7 days, and we got over 200 submissions, and they weren't all like bot submissions, some were. A lot of them were local submissions from partners.
What does RFI stand for?
Request for information. So we got over 200 of those, and we reviewed every single one. That's what the 30-person subject matter expert team did for an intensive 2-week period. We also held multiple community meetings in rural communities, including the governor had a North Country summit, which Ed was at, but he's out of the room, so I was going to just cover him. And then we did meetings with our safety net provider groups and their professional associations. There's a huge emphasis in this grant on supporting community mental health centers, federally qualified health centers, and rural hospitals. So we engaged with all of them. And then this is another sort of outcome of this that is, I think, going to be truly transformational. The governor decided that she wanted to establish a governor's office on new opportunities and rural transformational health. It's garbly, but the shorthand is Go North. So there's going to be a new unit that is co-led by the governor's office and the Department of Health and Human Services. The goal behind that is to sort of have the ability to very much interact with the governor's office and have a bit of the like, you know, influence of the governor's office, but to tap into the administrative structure of the department and to be able to pull people that are in the department that have existing expertise to be able to quickly start to do this work. So she had an executive order, I forget what date, sometime a couple weeks ago, and established Go North, which will ultimately report to the commissioner of DHHS and the governor's office. In a nutshell, this is what the crux of our application was. It very much aligned with the federal Rural Health Transformational Plan, which is any grant writer knows, you just write to the notice like, oh, what a great idea, we're doing what you said we should do. And I just include this map because it gives the real sense of what we mean by rural here in New Hampshire. So the green is what is defined as rural by this grant. I think I might have heard a chuckle. Yeah, it doesn't necessarily.
What's not?
Yeah, what's not? Yeah, there's very little that's not, and if you look at the little pinpoints on the map, those are where those different safety net provider locations are. And thankfully, they just said, oh, and all of those are rural too. So like the FQHC in Manchester, rural.
Well, I think that's because FQHCs were written in regardless.
Yes, yes. So it's really statewide.
I mean, I left an MSA that had 100,000 more people than the state of New Hampshire, so that's why I smile. I'm like,
I'm really struggling with that. I'm sorry.
sure, go ahead.
No, I'm really struggling with that because So last week, I was at a meeting, a healthcare strategist in Massachusetts that I spoke at, and this issue was big there. And then I was just in Washington yesterday where we had the opportunity to actually speak with heads of executive departments on this stuff. And I asked them very specifically, I said, from a population basis, and what we're trying to accomplish, I find it weird that we're leaving out the inner cities.
Yeah.
And I asked them, well, was that an issue? And they basically said, oh, whatever strategies you can use here, you can fix that with them too. And I said, I don't think it works that way, and you're not funding that. And so I'm very confused if we can use this money for Manchester or Portsmouth or Concord or whatever,
what
Nashua.
Concord, we can.
Will be,
We can?
Concord is
They
rural.
told me
Yes,
somewhere we
half
could
is
not.
Concord.
I was told that very
Yes.
specifically.
So I think when you look at it, it's, again,
Or maybe it's half of where.
Whitney has much more in-depth on this. My understanding is all the FQHCs, so there are 1,400 grantees, or FQHCs in the country with 18,000 care sites and 31 million patients. So when you get to the urban, to your point, the primary care in urban areas is probably almost exclusively delivered through federally qualified health centers, partly because of the sliding fee scale of their locations. So an interesting thought is to the degree which all FQHCs may apply for these monies regardless of their MSA. Then you start thinking of them as a hub to the broader spoke. So they are a legitimate entity to address some of these goals. So they would have to write the RFP. They may want to have some strategic partners who do things that they don't do, like housing or food. So it is a way to address your question, but you have to, if the FQHCs don't stand up and create that opportunity, then that urban area won't get helped.
And one thing they definitely said is you cannot use this money to build infrastructure. You cannot
Can't
build
bricks.
buildings. They said that.
You can-
Listen, I'm gonna get into that.
All right,
They
because they
said a
told
lot
us
of
we could not
things.
use it for that.
We put in, so there was a % limit on capital improvements.
Okay.
They're being, what's the word? They're disagreeing, they're conflicting. We know we can pay for renovations. What degree of renovations is gonna be part of our negotiation with CMS. So at the beginning of December, we will have negotiations about the final budget amount and what can and can't be included in our budgets. We did budget for the maximum % allowed for capital improvements because we know that that's a huge piece of financial sustainability for these safety net providers.
And it lasts. When you invest,
Yes.
you get 20, 30, 40, 50-year timelines. So
Yeah.
these, when I look at any time I can invest in something, it's one-time money, how long will this last? How long can I make this investment last?
And they did emphasize they wanted sustainable projects.
Yeah.
That is, they didn't want this to be
Yeah.
throw some money at something and it's gone tomorrow. This is supposed to be, that's what they
Yes.
emphasized.
Is it the same set of restrictions on the first 100 million as on anything beyond
Yes.
that? Okay.
Yep.
Great, thank you.
It all kind of just swirl, like, once the application is done and the scoring, it just becomes agnostic which amount of money.
Okay.
And they, yeah,
Interesting.
they'll
All right,
even
thank
claw
you.
back below that 100 million if you are not successful. So you're not
Yes.
guaranteed that base.
So if they claw it back, you don't get it next year either, right?
It could go up and down,
Oh,
so it's
okay.
gonna be a wild ride.
Oh, so it could go up.
Yeah, and we could get over 200 million if
Yeah.
another state is
Correct.
failing. So
Okay.
like the deputy of
It's a Hunger
Medicaid
Games.
is was at NAMD and thought, oh, I'm gonna get all this information from other states, and then everybody's being
No.
cagey. Like, it's like,
Right.
nope, I'm not talking about what we're doing, like, so it's kind of like a Hunger Games for the states.
That is so
Interesting.
sad.
But,
The statute is not very long, that statute.
I'm sorry if you are going to get in this, but it seems like, based on what Dr. Nagel said and based on what you just said, on the improvement part of it, there is a green or gray area that people are not dictated what to do with the money in that regard.
Yeah.
But do you really trust that's the case if we are hearing what he heard, that we cannot use it for this, and then you are saying, no, there is some green area, especially that we are going year to year,
Yeah.
and we don't want to fail or whatever.
Yeah.
I don't want to use, because that's not who we are as a state. We don't fail, but to use it in something that we're not supposed to,
Yeah.
and then put us in that jeopardy of not knowing what goes.
Yes.
Is what I'm saying make sense? Right?
Yes, it makes total sense. I didn't get into the structure of Go North, the new unit under the governor's office, but there's a large component of that unit that's all about compliance and making sure that we're completely following the CMS guidance so that we don't get into a situation where we have improperly used the funding and have to pay back.
Because what we did have here as somebody who sit here based on housing, capital improvement, like anything infrastructure, you cannot build or do anything
Yeah.
without that.
Yeah.
So if that's not part of it, then I think there should be a review or other conversation to do so. And what I don't know, the 100 million that is a guarantee for every state, and the next 100 that we all hope to get, there will be more restriction or more, I don't know, guardrail put into that to dictate to us what to do with that money based on those responses that the state or each state will provide, will guide the decision of how much we will give each state.
I didn't clarify this at the beginning. It's not technically a grant, it's what's called a cooperative agreement. And that means that each year will be issued a notice of award with terms and conditions. So we'll know like each year what the terms and conditions are, and they can change those from year to year. Again, we'll see where they fall on the capital.
Tori just was kind of asking
Yeah, that's
about
an important question.
kind of sole source versus going out to bid, and that might be later in your presentation, I'm not sure.
Yeah, and I am sensitive to the time. I think you only had me on the agenda.
Well, it's okay, we can go a little bit beyond,
Okay.
I mean,
What I'll do is I'm gonna stick through the detail of the grant, and I want to talk more about the council's potential role in the grant, but yeah. go
I
ahead.
have two very quick wonky questions if I could.
Sure.
One is, does the money arrive first and then we spend it, or do we have to draw it down and build for it?
I don't trust my answer, but I'm pretty sure it arrives first.
Okay,
And then there is a little bit of like flex in terms of saying that we've expended it if we've encumbered it.
okay. Second, where does the interest go?
I don't know, let me find out.
Okay,
It's a great question. That was actually one of the FAQs during the writing, was one state just wanted to put all the money into a fund and like draw off the interest, and that was not allowed.
okay.
So
I guess the point to that, but
yeah,
Yeah.
yeah.
So it's going
that's how every
on
institution does it.
executive
They just-
order online, if we can go read it, or?
Yeah, the executive order's online. I'll send it out too.
Okay, good.
So I will quickly just touch on, a big emphasis of the grant is strengthening existing partnerships. That's part of what I want to talk about today. The council is a partnership. And we heard loud and clear from all the community inputs we had, like, please do not create something new. Like, please identify existing things and leverage those, because when you create new things and then grant funding goes away, it just sort of, oftentimes disappears. And so.
Can I just say, so this is, I understand that for the beginning part of the process, but as we move on in the next 4 years, we can start to become more creative, right?
I don't think this stifles creativity. It's that, don't reinvent the North Country Health Consortium, don't
I
reinvent
gotcha.
public health networks.
least in the beginning.
Leverage the partnerships we have
Yep,
Yeah,
and use those as a foundation to be creative.
yes.
okay.
So we don't want a creative thing hanging out on its own, not connected, untethered. It makes the last thing we need is another tax ID number in this state.
Yeah,
We should have fewer tax ID numbers, not more tax ID
Correct.
numbers.
Gotcha.
But
Because
how-
there's too much administrative overhead for too many, too small not-for-profits.
And how are we going to bring those that are looking into having, like you said, tax ID, because they felt that maybe he was not doing, the one that exists now were not doing the job, or were not really touching them or whatever, because I think many organizations that we see, people are creating them because they felt that either the population they represent or other is not being served.
So
Yeah.
Rochester, New York, I won't go too far, but has a model that at some point in time, United Way said, we will not fund any more new tax ID numbers, and if you don't have a budget over $10 million, we cease and desist funding you, go find a partner. So we took on the lead coalition. They were too small, too much admin, which means for all those people in the C-suite, get your resume together. Because it's too much C-suite, not enough people doing the work.
I mean, I think the other thing,
It's a golden rule.
the
Who
other,
has a goal makes the rules.
in order to be successful, like, I think early on, I was prepping for the North Country Summit, and I had asked Ed, like, what's your one sentence that you use to describe the context that you're delivering care in? And it was verbatim what you said earlier
Too
today.
few people over too many miles.
And I really think that this is a key piece of the way that we're gonna design the grant, is to account for the fact that you can't create more and more, you know, entities, because there really just isn't enough in a community that's rural. And also, like, to the earlier point, I didn't want to get into it, but it's relevant, to get sufficient volume to be sustainable, we probably do need to engage with those non-rural communities to just actually like combine and, you know, so if you're doing telehealth specialty or something that can be accessible from those other communities, that's going to keep
You know,
things sustainable.
I worked for the Indian Health Service in Alaska. We covered the entire southeast coast with 6 doctors. And we used a hub and spoke model, and we used telehealth 40 years ago.
Yeah.
Because that's how you did it. And the model worked unbelievably well.
Yeah.
So it does work, and that's why I'm a little disappointed that states aren't communicating with each other on this, because states do have strategies that work.
I know, and we will try to do
Most
like,
of their strategies at work are actually published.
yes,
So they can try to hide them, but they're already in the public view.
yes, yes.
The cat's out of the bag.
Yeah, if anybody's wondering, you can just find everybody's applications, not New Hampshire's, on a website.
So we need tie those people's hand in a sense that they need to extend their reach, because you are in the C-suite, doesn't mean you do whatever you want.
Yeah,
This is a public money.
yeah,
I think it should be tailored to help
yeah.
everybody in a sense that, yes, we don't want another tax ID, but we don't also want people that already have a tax ID that think they're doing the work
Yes,
to be in their silos, keep helping the same people and forgetting the rest of the community.
yes. And I think like the, Jennifer's presentation was a really good one to sort of even think through some of this, of like, when you start to talk about prevention and really like moving the needle on something like prevention of opioid overdoses by being upstream in schools, you have got to work across so many different partners. Like, that's not a one agency solution. It really has to be, you know, bringing all these different people together. So I'm just gonna quickly, because again, I don't want to shorten.
Yeah, but
your
I
time.
think the only reason I would not be rushing you is that I think what you're gonna talk about will probably
Segue.
impact.
Okay, okay.
Oh, the other thing that helps here.
This is clearly very, yeah, we could go on.
I love this group.
This is the challenge with the $1 billion grant. And so,
Yeah, you should get like a minute per billion.
I know.
Yeah.
So I will fly through because I want to get to the, how does this council work on this moving
Yes.
forward? Because I think that's sort of where we're all headed. So a lot of emphasis on innovative technology and care models. Representative Nagel's like mention of telehealth and the hub-spoke model. All of those sorts of ideas are written into the New Hampshire application. But again, to the point that I made at the beginning about it being granted strong, we did not make a decision at the state about what was going to make sense at a regional level. So there's not sort of written in there like every region's going to do this approach. There's just a lot of different uses of funds that are going to be allowable. The care models is, again, like across those 200 RFIs that I talked about, it was like, it was starting to crack me up because it was like, we're going to have every community gets a community nurse and every community gets an MIH program and it's like, then you will not have, to the point that Ed made, you will not have the volume to sustain too many innovative care models. So we have to kind of collaboratively figure out what's the one that's going to work for delivering home-based primary care services. A huge emphasis of the grant is on growing the rural health workforce. This was probably the #1 priority expressed by the governor's office to just really make progress in this area. And again, the real New Hampshire flavor on this was to really focus on grow your own pipeline. So like if you have a medical assistant at an FQHC and they're interested in upskilling so they can be an LPN, or so to build those pathways and to truly offer that education from home. So not being like, oh yeah, you could drive down to Concord to get your clinical experience, you know. So that's a big piece.
If I could just point out, that model works really well in rural and urban settings together. The NHS, National Service Corps, has been doing that since the early 70s. And I'm assuming we can use, because now we have to go through statute to get that money, but I'm assuming you can use that money for those types of programs, am I correct?
Sorry, use the Rural Health Transformation Program for like National Health Service Corps?
Or something along those lines. That's just an example.
Yeah, so there is, to Ollie's point earlier, express guidance in the grant that you cannot duplicate funding or supplant funding, but you can expand on
we're not doing
existing
it.
funding. Yeah, so.
I heard it. I was in
I'm sorry, I
Lebanon,
should have interrupted.
and Lebanon was saying, people that were at the meeting was saying, when I said I sit on the Shaship, the things was that they get dictated from Concord what to do, and Concord is not getting more information from them rural communities, and some of them feel left behind. So I think there is a big scope of work that need to be done in that area, and that's why I'm bringing this. And of course, the many hats that I wear in this community, this matters to me, because each of us definition of what that healthcare means and healthcare outcome might be different. So I think people that will get the grant or privileged to get the grant should not take it lightly, to know that it's not your typical things that how you want to use it as always, but have a direction and see where the improvement have done. One time I want to speak and not to be on tangent, somebody said to me, oh, Ali, you just open our eyes because when you talked about DEI, I said anything that is different, I know it's a buzzword now, but anything that is different is DEI. If we never had something done in this organization and we do it today, it's DEI. It's literally diversifying the choices. So if Scott or anybody never worked with certain group or individuals or demographic areas like locations, and you added that into yours, you diversify the choices and the options and the access that we are talking about here.
And to your point, again, I know I'm running over a bit, but like we built in a huge piece. They wanted eval, but they didn't make a huge emphasis on evaluation of the grant. But we went ahead and wrote in for, again, this is partly what's transformational about it. Like, it's the most real-time eval that we've, because again, we have to ensure that we spend and that we're successful with our metrics. So like, I look at Scott and I, you know, we're the old-fashioned public health people that are like, we'll check in a year. And then everybody's like, yeah, some stuff happened and it didn't work out. And you're like, oh no, but so we can't do that.
It's funny that she looked at me and was like, oh no.
Well, he's worn all the hats.
Yeah.
But
I do think it's fascinating that I like the fact that it isn't so, most of our stuff here is very linear. It's like, it's one thing doing that, you come up with 3 outputs and you're gonna make sure you measure those 3 outputs. And the reason that you wait a year is because you're not gonna see anything. This is actually so much more. So.
It's multimodal. And the way you presented it, it feels descriptive, not prescriptive.
Yeah.
Which I think allows for customization of tell me what you're doing, how is it transformative, how does it meet a need, how is it sustainable, and then you'll get to it, but tell me how it fits the ship. Like, is what you're doing transformative? How does the transformative work deliver on what the State Health Improvement Plan looks like it's important. Which box do you check?
If I take Washington at its word, what they told us very specifically is, we don't know your communities,
Yeah.
you do.
Yeah.
And this is your opportunity with our help to do what you need to do for your own community.
And-
And that is exactly almost verbatim what they just said.
And I would say then at the state level with the application, that was definitely reflected as well. So I am gonna transition so we can talk about the SHIP Council. Strengthening financial foundation, like I said, we budgeted in as much as we could to support capital improvements. There's all sorts of opportunity if safety net providers want to work on their financial, like revenue cycle management, use AI tools, engage in like ACO readiness so that they can enter into value-based payment models. That's really part of our thinking on how do we sustain this moving forward, is that we get organizations to a place where they're not necessarily relying on fee for service. And then it shouldn't be the last bullet, it should probably be the first bullet, but there was a giant emphasis on prevention and primary care, and to Jennifer's point earlier, that primary care is inclusive of like chronic disease, but also behavioral health and oral health and perinatal care. So a huge amount of focus in those areas. I'm gonna skip along. I already went over the Go North structure, but it's just to say this is gonna be really innovative in that it is a combined co-led effort by the governor's office and DHHS that's establishing this new unit. I'm gonna skip forward. We'll send these out if you want to see.
For some reason, she asked me for screenshots of my insulin pump. I'm not sure if she was going there.
Well, because I have gotten good. I won't steal photos off the internet because that's naughty.
Right.
And so, but I wanted a visual for remote patient monitoring.
okay.
And I was like, Scott, because he walks, what do you, yeah, you got two.
Yeah, I got
devices
multiple
for the
devices.
diabetes. So I was like, can you send me a screenshot? Because all that stuff is, again, like, we're not prescribing, like, we got so many things through the RFI from different device companies, and it was like, we don't know the right device to purchase.
They come out of the
like,
woodwork.
Yeah, I mean, the number of different
They smell money.
remote monitoring devices, and then you have an entity like an FQHC that's then trying to integrate it into their electronic health record, and it's the wrong one. So again, not some of these things. So the final piece is I skipped forward. So what we put into our we put the Shaw Ship Council in the application because I felt like I had presented earlier to this council, and there was generally support for like, yeah, like this council could serve in a role for this grant. And so Ed, I think, kind of foreshadowed. So I put in that the Shaw Ship Council would serve as a statewide group to help with partnerships and implementation of the Rural Health Transformation Program. We wrote in this like broad term called regional governance groups, and this gets to the idea of like, we need some, and we did that at an existing geography. Everybody can breathe a sigh of relief. The department did not create new regions, which is again transformative.
Like those tax IDs.
Yeah, okay. So we went ahead and aligned with the regional public health networks as the geography that we would use for regions. But we did not specify, and we said that we want to identify, so we want regions that come up with governance and make decisions, kind of to Ollie's point too, like we don't want people just going rogue and being like, I'm doing this while
Right, yeah.
Yeah, so we want to have a little bit of that coordination because we think that's critical to having impact, and then also, again, that long-term sustainability of like, are you going to have volume? Do you have buy-in? Like, how many times have we worked with places that they want to open some sort of new program, but they don't actually have buy-in to get referrals to it, and so they stand it up and put in all that work, and then nobody comes. So, we said we wanted to create this regional governance system. We wanted to, again, to that conversation earlier about TINs and existing groups, we just wanted to identify an administrative lead for those regions. But again, like an existing entity that just, has the ability to convene and to potentially administer funding. So I wanted to just get people's initial thoughts on like, what could the role of the Shawship Council be relative to this? I had thought, and what I wrote into the grant was like, this really fits with the
Mission.
statute of the Shawship Council, where we're supposed to really understand the whole state and then identify where there are areas that need to be addressed, and then even elevate things that need policy changes to be effective, implemented, sustainable. So I thought that could be a role for this group, that these regional governance groups could actually use us as a platform to say, for example, we heard loud and clear from FQHCs that when Medicaid tries to make a change, but it's not aligned with commercial payers and Medicare,
Drives costs.
yeah, it's not actually super helpful. So potentially elevating something around payer alignment to the SHIP Council could be really impactful. I will say we got a letter of support from Anthem around their willingness to partner around care coordination and paying for that in the long term and aligning with Medicaid.
I like where you're going. When I worked in re-engineering at an academic medical center, we re-engineered the pediatrics department entirely in 2 weeks. And every time that Dr. Nagel would say, well, radiology needs to do something, like, assume it's done, keep designing, and then we had a single point of contact back to director's offices, get radiology on, make sure they can do this. So I see as people are going over these 5 years, they may encounter legislation that needs to be rescinded or created to be transformative. And I could see this entity as that single point of contact. We got it, we'll run it up the Senate and the House and create the legislative language that we either rescind this or you can do this. Or, so I think that, and it fits within our charter of making recommendations. What I like about it is the local people, the local communities know where the barriers are. And they often don't know how to communicate to whom. It's too confusing. I don't know. I've never been to Concord. I don't even know who my House rep or my senator is, and I don't know how to make this work. So that in itself could be very transformative in the process that the state has for changing legislation or rules in a more situationally aware, dynamic way. I would like a law that says every time you create a law, you have to take 2 off the books. I can dream.
I'm struggling with, I think it's all really important, and I think this slide was actually the most important slide.
Yeah.
So I feel a little bad we left it towards the end. And I'm thinking about the pragmatics of it, and this is what my mind's thinking. Number one is that we need to meet more often. Number two, it dovetails well into the next discussion of subcommittees, because I think we can delegate stuff like this to the subcommittees.
And let me just add to that point of meeting more often. We're always trying to figure out where we are. And then
You're over at the medical office building,
But
right?
Yes, thank you. But before built on, I said, if I failed to see the address, if Scott put the address in, because last I saw was to be determined, TBD.
Oh, okay.
I apologize.
And it was never updated except room 312, and that's it.
Yeah, I'm sorry, that's it. I need to communicate more often. It had come out in another email where I gave some directions, but it needed to be put in the actual invite.
You didn't know where room 312
Yeah, come on.
Polly, I
Do
see
you have a
you've got
room
your hand
312?
Yeah.
Thank you. Am I unmuted? Can you hear me?
Yes.
Oh, yay. This is very exciting, and I think David started to ask pragmatic questions. I have a pragmatic question, and that is, do you see the role of SHASHIP as being an operational role in providing oversight and guidance to the implementation of the plan? If so, not only would we need to meet more often, but would need to have probably substantially increased support from state agencies. to help
It's like you read my
with the
mind.
process. All right.
Yeah.
Thank you.
Thank you, Paul. You read my mind. So what I was saying is like, thank you to Scott because he just stepped in and has been supporting the council
Thank you.
after the end of our facilitator contract with Brandeis. I definitely, I put into the grant that if we are going to operate as that entity like Polly had described, that we need support for, like, because again, like everybody's a volunteer. Although I was struck from the last council meeting, I think it was the last one, when somebody asked who's getting paid here, and like half the people said they weren't. And so I had also written in actual, like, not pay like per hour and mileage, but some sort of real appreciation for participation in, so anyway. Yeah, I mean, a bottle of water.
Or a lunch after 2 hours, 3 hours
Yeah,
meetings.
yeah. But
Since
so-
HHS has been underfunded, last I heard, that was an incredibly important question, but that oversight money, or whatever you want to call it, can come out of the transformation bill. That's okay, we can use that money for that purpose.
Yeah, yeah. So.
As I try to press record and find out where the feedback is coming from, and I'm like, yeah, I think it would be great to have somebody that has like a real
Still keeping it,
system, and then instead of me and a state laptop,
Yeah, or me
trying to
running
get Ally to
downstairs.
the right building. It's again, I think it's a fantastic way.
You know why I was confused? I live like 2 minutes away from here. Literally, where the nursing home, I'm on the other side on Prescott Street.
Okay,
And
well, 312.
when you said DHHS, because I go to the behavioral health
Okay.
meetings all the time,
We're
I said
terrible.
main building.
Yeah. We're terrible with directions, terrible. Anyway.
So Scott, that was not a slight of your
Oh, no,
efforts
no,
to
no,
help
no,
move
no.
us forward, just to be clear.
No, you have all been fabulous to work with, but again, when you're trying to ramp up and do more,
Yeah.
you do not want me trying to figure this thing out. You want somebody that, again, you look at like the foundation, they've got the facilities, someplace like that where you have, this is a makeshift operation for volunteers, which is great. If you're gonna be involved as Hal Whitney foresees it, you really do need to have. And it is a lot of work. I mean, we're trying to keep you all informed and making sure we get dates and all that kind of stuff. It's, it's a
I'm
full-time-
excited about it because as we sat and had great ideas on the ship, we all sat and went, that'd be great. Where's the money gonna come
Yeah.
from? So now, we're ahead, I think, in some instances because I never looked at other state ships. I don't have a good reason to. But I think we have a well-informed ship. And now we have boots on the ground. You got great requests for information. People are already thinking. They've got ideas. So I think it's a huge opportunity over the next 5 years that we may be able to accomplish a lot of the ideas on the ship at a hyper-local level where they understand this will work here. Someone else can go, I can take it and modify it to make it work in my community. It's not cookie cutter. The feds aren't telling us what to do. The state's not telling us what to do. It's coming out and going, you have a challenge with addiction, substance use disorder, or food security. What do you think you could do?
Yeah.
Like if you had the money, what do you do and how do you sustain it?
And to Dave's point, about kind of integration and how do you make sure these are known between communities?
Yes, yeah.
And the feds aren't telling us what to do, but they are telling us what to do.
Yeah.
I mean, it's not like they've divorced themselves from the process. We are gonna get graded.
Yep.
And I will say that was neat for me when I spoke at that meeting in Massachusetts, somebody, who was some big cheese in some administration post, came up and said New Hampshire is doing really exciting things. She said that to me very specifically, so you're doing a good job.
Awesome.
And we really appreciate that.
I will second that. I stress that. I didn't even know this was a thing because literally we know we cannot do work or good work without funding.
Yeah.
And now we have the funding, and now you are putting more responsibility on this ship that was created to do this work. My question is now, you highlighted all this, and I love the committee work, and Dave and I had lunch and we talked about this. How often the ship goes even to city legislators, or how do the legislature knows the role that this ship play? not only being at meetings, but even being ambassadors in the community. People that ask you, oh, I heard you are on this, or I heard you are on this, and then you are trying to educate the community at large what this meant, I think goes a long way. And for you with me to highlight this, where you see the collaboration, partnership, and the impact can be made by the ship on this entire thing, incredible.
Awesome.
And just some really talented people all the way around, from communities to DHH. I think that's the most exciting part to me, is you've got everything you need. You've got great people, you've got a lot of money, you've got, you know, communities that will actually can really benefit from it.
I think it's a high trust, having lived and worked in New York State, nothing against New York State, they can't, there's too many degrees of separation for me. I would never have the cell phone numbers of people that I have here. It's 1 or 2 degrees of separation. You make a phone call, I can help you out. It really behaves like a metropolitan service area. So we're very facile in being able to get things done, because we kind of know, I don't know, but you do. So you could make the introduction, and we could get together, we could do something. You know, at least at the hyper-local level, I sit and look during the pandemic in Bethlehem, where I lived, and in Littleton, no business was closed. That is unprecedented. Everybody, you okay? Everybody looked out for each other, and I think that amplifies out to the state level. We're not perfect, but I would, if I was a Benton person, I'd put us in the top 5 states of being able to make this work very well. I think the big states will struggle. They're just too big to get out of their own way.
It's funny, we have, oh, go ahead.
I was just saying, it's also less money for them. Go ahead.
Right. No, it was one of the things that we, you know, discussed with the VA. Why don't you regionalize what you do? Why do you have to offer it out of the big, I mean, and allow these regional groups to be much more independent? You'll function way more better than you are. And I brought that up actually at that meeting yesterday, and it's like, oh, you know, I don't know, because it does work better, and that is the beauty of a small state.
Well, I brought up, there's 18,000 care sites in the country of FQHC. We see 500 people who identify as veterans. All I need is my cost covered plus 10%. We'll see the veterans. We'll share the data with them. And keep your 800C box. Don't get rid of those. But we can amplify another 18,000 care sites for the veterans to get care.
We asked them that too. This is awesome.
We'll play.
Yeah.
I just need my cost covered plus a respectable margin, 5 to 10%.
And I think, you know, here we are, we don't have a lot of time left. I think it was important. Councilors, go ahead, Phil.
Well, so I was just going to ask relative to a role that SHASHIP could play in the application or in the cooperative agreement as it's structured now. What are the pivot points, flexibilities for if the state isn't able, and I know we don't know the amount of money now, but if the state isn't able or finds that it's falling short of spending that amount of money within the appropriate amount of time, what's the decision process for pivoting, reorienting, approving if the money gets moved somewhere else, and is that a role the council could play within a year? Right?
Yeah, it could play that role. I think what I was, it's great, again, this is we are a council together, but you each are also, you know, individually doing work in communities. And I want to be trying to be like sensitive to balancing like burden versus flexibility. So again, I think there's opportunity for us to decide what makes sense, but I wouldn't want to create like, you know, processes that could slow down innovation. So are you looking to chime in around that?
Well, yeah, I think so. So like the next topic was the subcommittee discussion, and depending on when we choose, it's not a 10-minute discussion, I don't think so. But with that said, you know, one of the things that we identified as a priority was how do we facilitate communication on an up-down, I hate to say we're up, but you know, hierarchically we are. Up, down, up communication. We're discussing the possibility of a subcommittee that would do that. That's an important committee. We talked about a legislative subcommittee that would stay on top of all these things. I mean, these are all things that we can do. If we're going to meet again, maybe, is it possible to meet in December?
Well, I think as a council, you can do whatever you want. I mean, we have been going on an every other month schedule, but I think that was kind of Brandeis with what they were doing, it fit because the work groups were doing the thing, but this is your council right now, so you can meet as many times.
We have all the folks out in the audience. It seems to me, I mean, there's two, I really think that getting that subcommittee structure up and going is important. We are definitely behind the 8 ball in terms of legislative discussions, which I hope this will be the last year that ever happens, and in the future we're more proactive, because you were talking about us being visible in the legislature. If we don't think about these things in advance, then that won't happen. So, you know, I think establishing that structure, deciding what was working good before when Palmyra was here and what's not, that discussion is really important, and I kind of would like to do it in December if that's possible.
Well, and I think
And
there
then-
was during the interviews, we did talk about, I think Tori was one of the people, there were several people who brought it, like having a year-long plan.
Yeah.
So it's not like we're getting together as a leadership group trying to fight together
Yes.
what's gonna happen this month. You have a, kind of at least a general description of what needs to happen in 1 month. And so that's
Because I think you're right, if there's a standing agenda item in the course of a 12-month cycle, here's when we have to talk about
Yeah,
legislation.
legislation has to be.
Because if we don't talk about it and get our thoughts articulated, we miss the opportunity to get things in front of the legislature because they have a life cycle.
Yeah.
So we need to feed.
Also, how do we get the right bills to look at, to talk about, to give that feedback? That's a
Right.
whole nother thing.
So if we have like a subcommittee structure, the main group doesn't meet every month. But what I'm thinking is if we do that last agenda item as a priority item in our next meeting, get that established, get that started, and then we can use that as a means of doing what you're saying for the rural health transformation thing. And now I'm excited that we can use it for inner city, or I hate to call New
Like
Hampshire inner
QX.
city, but you know what I'm saying.
Close as we can.
You know, that we need to get that established. And the other thing is, the other agenda item that I think is really important is everybody's homework will be to look through all the bills. And I'm sure you all know what's important now, but in your own worlds, but you know, and give us things that we should be focusing on going forward. Like we can set a number, we're gonna focus on 5 bills. Can we as a group testify when it comes time to testify, or can I go and testify, or Ed, or whomever?
Or at the very least, as some groups do, you're organizing and testifying, like obviously Wick and I.
Yeah.
Including yourself.
Because we probably are invisible at the
Well, people
legislative
showing up
level.
to testify matters, because I will hear sometimes going, well, why'd you vote that way? Well, nobody said anything. I didn't hear anything, so they just kind of they went with the group. You know, it's kind of, they didn't have anything to bring because no one fed them their constituents, and now they may not have sought it either, to be fair. They are volunteers, so there is that. One of the things I played around with, and I actually took the SHIP, and I took the community needs assessment, and I played with some AI, and I said, show me the overlap. And it still hallucinates, and it still requires a lot of guidance, like a small child walking across the street. Yeah, I've seen some value in taking things like Copilot and asking it questions and seeing what I get. Here's a federal legislation. Here's our policy format. Write a policy for me. And it gets 95% of it right. So there is some possibility to sit and look at, because as David's talking, I'm thinking, going, okay, I'm just going to take an AI, take the legislative language, take the SHIP language, and have it rank ordered and say which bills match. Now, I'm still going to have to go back and go, oh, no, that's not right. That's
I mean, it might be, Dave does have an interesting point too. I mean, some of you already do this, but it's almost like in our areas of specialty,
Yeah.
we see these bills, at least gathering those together.
My state does that for us. The Foundations for Healthy Communities has a set that they focus on, and you know, the housing people have a set that they focus on, and sometimes they overlap.
What we learn in many other settings is that even if this body cannot be at the legislations, can I speak today? If this body cannot be in front of legislators and testify, who are the partner we can identify that has that power,
Right.
authority, and flexibility to do that on our behalf, where we can send certain information, educated information, or even stories to them, so they can, you see many entities out there has coalitions or groups that they partner with, and we stressed many times here the importance of partnership.
Yep.
And some people don't have anything to jeopardize. They don't get grant money from federal or state money, so they have that opportunity to be there, like Able New Hampshire is a good example here that can be an advocate for certain ableism stuff related. So I think we need to be very strategic, but we need to make this a powerful council that we know we all have the expertise and experiences to bring to these legislators and to listen to us on what the needs are.
I was just thinking of a military analogy, but the Defense Early Warning System, that I assume still exists, but, you know, we can serve as a conduit, like if somebody within the SHA-SHIP sees a legislative issue, we can be the organization that filters that information out to everybody. So we don't necessarily need to testify on our behalf as a group, but we can let all of you know it's a priority, because somebody, you know, in Groveton or wherever, I had to pick a random rural
It's fine,
setting.
that works.
But, you know, here's something, and then we can just filter that out to everybody and almost have like, I coached and I ran a Little League and I ran a Boy Scout troop, but we can have a phone tree type system, except I'm sure that there's a much more technologically sophisticated.
Well, and
way
I
to
think
do
some,
that.
it kind of, to Ollie's point, some also, and you're in a good position to help with that piece, is like, if a legislator has a question, they're writing these 1,000 bills right in the very beginning.
Yeah.
Is there some way we can kind of help with that process?
Because I think there's almost 1,500, right? I mean, there's a lot. I haven't even looked through them yet. I'm just so busy
So
with
you're
my
talking
own.
about the LRS?
LSRs, yeah. Yeah, there's probably close to 1,500.
And I'm always struck by, like, there's like, usually like 5 on the same exact topic.
Sure, don't they talk to each other?
No, we don't. Well, the Senate does, the House does not.
We got, 420.
Well, I know we're coming up close on time, and I know
We
you like
do.
to actually ask if there's any
Yeah, well,
public comment.
by law, is there any public comment from anybody? And the only thing I feel bad about this meeting is, and I'm not sure we did a great job, and we can discuss how to do this, but facilitating conversation from the people that work here. I
It could be the room.
feel really bad about that. But anyways, is there any public comment?
Or even just.
Any comment?
I think Megan's
Oh, I'm
asking.
looking, can you write these
Ferrets
down?
for hunting.
Thank you, Tori. Oh, it's like a good.
I've never
sorry,
thought
sorry.
about that.
I have to tell you why those are coming up. That's a joke.
Oh, okay. 'Cause
Oh, I was gonna train
I don't know
ferrets.
why, maybe it isn't,
Being
but
allowed to have a raccoon as a domestic pet was like a hot one last
Oh,
session.
Yeah. Have you ever gone hunting without a ferret? It's
What?
not as much fun.
No, you're not technically
my
allowed.
wife's about the same size, but I won't go
And
hunting with her.
muted. I don't know.
Megan just had asked if we want to do a meeting in December. I am willing to do that.
Yes.
And do we have a hand up? Ann, sorry.
Yeah, the newbie here, this is only my second meeting. So I think having a meeting in December or having a meeting more often, because I feel like I'm having to re-educate myself each time. And I found a lot of value in what you were talking about today, especially with the legislative stuff coming up.
Things are moving so fast right now, and especially the whole Medicaid thing. I mean, that was a huge topic of discussion at both of the meetings that I went to. So, you know, and there's rule changes, reconciliation between state, federal, like what's a medically fragile person? You know, they haven't even defined that.
I know.
You know.
Well, they
but
also, this DHHS today talked to the legislators about the back of the budget cuts, which are always an interesting conversation, because they still haven't landed on what that is, and that's money that's going to be taken that we have no idea what it is.
It's a scary world.
Kafka.
So yeah, we can certainly, I know there's been some people that had some issues around the time on Friday too, so we can maybe look at all this at once and try to figure out a good time in December. I know December's hard,
I know.
big holiday season, but.
I don't have any friends or family, so I can do it.
Yeah.
So
That's good. My family would prefer I was here in this room,
I'm just joking.
waiting for Ollie to get here, but that's all right.
Well, I don't have friends, but I do.
So, yeah, so any other comments? Thank you, Ian, for chiming in. We got a few minutes if anybody had any other thoughts, but we can certainly,
So the plan is to send a dual thing for the December meeting, or we already have a date?
yeah, let me get with Dave and Ed and try to figure out like when they're available, and then we can give some options. And then, because I know Ann Landry can't make this time because she has another commitment, so there's been a few. It's always hard when you have 35
We know the
people.
20, we'll end up having 3 choices, 5, if it's Friday, 5, 12, and 19.
5, 12, 19, yeah. So then we can just give some different times on those days and figure out if anybody-
26 is Boxing Day.
Earlier or later, because for me, between 1 and 2, it's service time, that's why, so I'm heading.
Yeah, sure,
No
yeah.
wonder.
Yeah, and I think we can, it's a good time. We've got 5 or 6 new members to try to figure out what's.
Okay.
I
So
think,
yeah, barring any other comments, we will share the slides.
thank you.
We will share the draft meeting minutes, but we will not post them until we actually come back on December and vote. So that's
And we
it.
can't share the snacks because we don't have the 3D.
I will share the slides, and I will go to jail for that. If that's, I will take one for the team.
I have a question, I don't know if we have decided this previously or not, the AI note taker. Some meetings will say, no, I see we had one. that
Well,
just
that's,
passed."
yeah, Senator Prentice does have that. Yeah, we can talk about that.
Okay,
I think,
I mean,
we'll have
that's
time
a-
to talk about it, but I'm seeing a lot of happy Thanksgivings and safe travels.
Yes.
Same back to
you're right.
everybody.
Yeah.
Thanks.
thanks, yeah.
Bon chance.
Bon chance, merci.
And welcome to all our new members, and
Motion to
goodbye.
adjourn.
Do we need a
Thanks,
motion?
everybody.
Motion to
adjourn.
adjourn.
Oh, motion to adjourn.
Do we need a
Second.
motion?
I don't know.
Some of the groups don't just say, we're adjourned. I
Okay.
can do what I
We're
want,
not
I'm
doing a
a
roll call
dictator.
Yeah.
Thanks, everybody, for coming, this was awesome.